Are there any questions?
Yeah, when do you determine when you do radiation? When you have
The question is, when do you use radiation? So, in general, we think that kidney cancer is not a radio-responsive tumor. In general, there's been this concept that radiation doesn't work for kidney cancer. That actually has changed quite a bit. We now use radiation for metastases that grow when other metastases are stable. It's actually offered through a clinical trial that we're going to be offering at this center at some point, where if patients are on a drug such as Sutent and their cancer, certain parts of the cancer grow and the rest of it stays the same, we're going to radiate those spots that are growing. And they're called oligometastases. Oligo means small or less metastases, and we can radiate those areas to respond to it. Now, the other role for radiation is because we have changed our concept that radiation does work for kidney cancer, is that there's some patients that can't have anything. They can't have any drug therapy because of problems with their heart. They can't have surgery because of medical issues. They can't have RFA, and so they're out of luck. We now have an option of radiating the tumor. So this is all very preliminary, but we have some patients where they have no other option. We're radiating the actual cancer that can't be removed and having some reasonable responses. So again, it's very individualized in terms of when to use radiation. In general, the mainstay is always surgery first, and then one of those drugs afterwards if you have metastatic cancer, with radiation specialized for the situation.
Quick question. Have you come across studies or being performed on intraarterial infusion of chemotherapy similar to TACE for liver?
Yeah.
Transarterial.
Yeah, so I think we do have intraarterial chemotherapy specialized for bladder cancer and some other similar types of cancer, but not for kidney cancer because it's an oral agent. So because it's an oral agent, we don't have any studies using intraarterial therapy for that. We do have, if patients progress on the oral agents, then we sometimes offer 5-FU gemcitabine, but not intraarterial.
I had cancer, kidney cancer, 2 to 5 years was what I was told in December. Is there any test or any scan or blood work that could have been done that I could have known about? Because I had absolutely zero pain.
So you had kidney cancer 5 years ago?
2 to 5 years. For 2 to 5 years before, without knowing, prior to my diagnosis.
Oh, I see. You had it for a long time before you were diagnosed.
Yeah.
Right.
So is there any scan or blood work that?
Well, that's a great question. I mean, most kidney cancers now are picked up incidentally. So yeah, yep. So we used to have this old triad, or this historic triad, where you had blood in your urine, or pain in your side, or feeling unwellness. That would be the harbingers of kidney cancer. That's only about 5%, 10% of patients now. Patients that come to emerge with blood in the urine have a big cancer. We don't see that as commonly now. Most of these are picked up by accident. I think at least half my patients had pain in their gallbladder and picked up a tumor in the other kidney. So we picked up a lot of those by accident, fortuitously, because we can save their lives. But we don't actually have a blood test to check for kidney cancer, not yet, and not routinely. So if we could get a urine test to check for kidney cancer or any cancer, or a blood test, that would be great. That'd be fantastic.
So what can one do?
Well,
I mean, I all my friends are, well, what can we do to see if we...
What I tell patients that they have a history of kidney cancer is because there's two types of, there's two types of ways to get cancer. One is hereditary or environmental. If you smoke a pack a day and live the rough life, you can sometimes get kidney cancer from that. Or it could be hereditary because you have a family history of kidney cancer. So what I tell patients who have kidney cancer that don't have any risk factors is that get your siblings checked and your children checked with an ultrasound, right? Because an ultrasound is harmless. Now, routine ultrasound check of the entire population, that's a tough one because kidney cancer is not that common. It's considered a rare disease, I guess, although it's not that rare really. But to do a routine ultrasound of everybody in the entire population every year would not be tenable, right? It's not really, we can't really do that. The system would break. But it's not just kidney cancer, pancreatic cancer, liver cancer, everything. Those are all silent, right? Ovarian cancer, those are all very silent. You don't really get any symptoms until they grow. So an ultrasound would be a way to screen for that, but it's tough to do that on the entire population. So I don't really have an answer for you. It's a tough one, for sure. But the minute you have any sort of twinge of anything, an ultrasound is a very, as you saw from the talk today, it's a very harmless, no radiation test, and an ultrasound can be quickly done, and I think I would encourage that. The only blood test would be what's called circulating tumor cells, which is really where you take a blood test and check for CTCs, and that's really a laboratory test. It's not really practical to do that on the average on everybody. So.
I think what I'll do now then is just read the questions that have come in from the people in the audience. So the first one from Joanne, what tools are available so that I can manage the amount of radiation received from X-rays, CT scans, SBRT radiation, etc.?
So that's a good question. It's unfortunately there are no kind of dose meters available. I know certain institutions in the US, they have what's called radiation passports that logs in the amount of scans and the amount of radiation the patient has had. Again, it's not widely used or available. The Radiology Society of North America, the RSNA, and the Canadian Association of Radiologists are all working in tandem to bring out something on those lines. And also there is a Image Wisely campaign in the whole of North America. So it's all part of the bigger picture to reduce the number of medically induced radiation.
So just give an addendum of that. So a lot of patients that have localized cancer, stage 1, 2, or 3, ask about, how often do we follow up? We have the guidelines outside from the Canadian Urological Association. Those are in 2008. They're going to be updated. But basically the way that I stratify it is low, intermediate, and high risk. So if somebody has a T1, a 4-centimeter lesion, there's two things that help you stratify how aggressive a cancer is. One is the grade, and one is the stage, or the size. So the way we grade kidney cancer is grade 1 to 4, 4 being the most aggressive, 1 being the least aggressive, and the size is how large it is. So if somebody has a T1 or a tumor less than 7 centimeters, grade 1 out of 4, they don't need aggressive CT scans. So that minimizes your CT scan because your risk of cancer reoccurrence is so low that the risk of radiation is greater. So I just do ultrasounds and a chest x-ray every 6 months for 5 years. Now if somebody's in a high risk category where they have a larger tumor that was removed, maybe even positive lymph nodes, then I'll be more aggressive with a CT scan every 3 months because they're at high risk for the cancer coming back. And we want to be on top of it to make sure that if there is an area of cancer that we can treat it aggressively, and it can be, if it's a small area, we can treat it surgically. So it's called metastatectomy. If somebody develops a small lung nodule and you catch it early, you can re-cure that patient by taking out that lung nodule, including even if it's in a piece of bone. Sometimes we've done removing of a piece of a bone where the cancer is, and you can cure that patient again. So we're very aggressive about that. Depends upon the risk stratification, low, intermediate, or high risk.
Just on what you were just saying about nodules in the lungs, what if there's very small, but like 3 or 4 in one and 1 or 2 in the other? Are they still able to be removed even though there's multiple in both lungs if they're very small? Like less than a centimeter?
Yeah, that's a little bit tougher because if you have multiple lung nodules, it's hard to remove parts of both lungs because then you have trouble breathing afterwards. So we don't usually recommend that, but one of the concepts as well is that's where you have a multidisciplinary approach to it. We have a surgeon, a medical oncologist, and a radiation doctor to talk about it together, where you might want to go on a drug for 3 months and then see what happens to all those lung spots. If they all go away except one, then do surgery on that one. So it's always a combination and individualized to that patient.
Can I answer this question as well?
No, I already answered it. Oh, go ahead.
Sorry.
One other thing about that, when do you get to a point, like how large do they have to be to begin any treatment for it? Like if it's only 3, 4, 5 millimeters, 7 millimeters?
Yeah, that's also pretty subjective, to be honest, but our guideline is 1 centimeter. So if it's less than 1 centimeter, you see the radiologist say these are sub-centimeter nodules, and in general, we sort of say that maybe that's not of concern, but the key is growth. So if you have multiple spots in your lungs, even if they're small and they never grow, they're probably nothing. They're hard to biopsy, they're so small, right? Depends how slick your radiologist is, right? So if they grow bigger, right, then they're probably metastatic, and then you have a problem to deal with.
Again, coming back to the lung lesions following a metastatic spread from the kidney, the options are again surgery or radiation. So some of the newer treatments like the ablation, which I discussed earlier about for the kidney tumor, radiofrequency ablation is a recognized treatment for lung metastasis. It's being performed in Toronto, but not here yet in Hamilton. And it's been offered in many centers in the US and some of the centers in Canada.
Again, it has to be 1 centimeter.
It can be up to 3 centimeter, and it can be up to 4 lesions in one lung.
That 1 centimeter is not a treatment guideline. It's just a guideline in general that maybe there's a spot of concern, but that's just on a one-time image. If you have if you have a 3 millimeter spot that goes to 4 millimeters and 6 millimeters, that's a problem, that spot. But if the 1 centimeter spot is...
It could begin sooner than 1 centimeter
Absolutely.
if they know it's growing.
You asked for a general size that we worry about lymph nodes or lung nodules, that's a general size.
Okay, and the ablation can start before 1 centimeter?
It can. It depends again on the index of suspicion, whether it's growing on serial scan or if the biopsy has been performed and that's been proven as a metastatic disease.
Thank you.
So I'll go to another question. Deb, this is for you from Joanne. With all the side effects of kidney cancer drugs, radiation, stress, etc., could you make a comment about the benefits of palliative care doctors who seem to have some expertise in dealing with the side effects of cancer?
Okay, I'm going to fess up. I'm going to fess up that for years I have been wrong about palliative care. Because for years and years I... Did you get that on videotape? Okay. I'm wrong. I once said, I think in a meeting, if my doctor ever mentioned palliative care, I'd hit him over the head with a 2x4. And that was wrong. Because what I have learned since is that palliative care is about a whole lot more. And it's about symptom management and helping people stay well enough that they can stay on treatment for longer. So I could argue that anybody with metastatic disease could go for an appointment with a palliative care specialist and just get some help with coping, with some nutrition, with some weight management, whatever you need help with. Maybe they'll put you on an exercise program and give you some energy back. So there, I've said it. I was wrong, and I think I would recommend it.
Just an addendum to that, we've renamed it. We don't really call it palliative care anymore. We call it symptom and pain management. So it's a symptom and pain management doctor because I personally use a lot of symptom and pain management expertise, the old palliative care, just to help patients with pain control and other things. So I think it's a great idea.
Thank you. The next question is from, I think Lutz is how I would pronounce it, is from Kitchener. My question concerns one likely cause of renal cell carcinoma. Is it true that patients showing renal calculi are at a substantially higher risk for renal cell carcinoma, calculi being stones, kidney stones? If so, when such patient had been removed a primary tumor, example by partial nephrectomy, could subsequent kidney stones cause a second primary non-metastatic tumor? Wait.
So that's a very provocative question, actually, because there is a study out of Malaysia suggesting that patients with a history of stones, chronic stones formers, have a history of may be at high risk for developing kidney cancer. I would say that's. I think the data is lacking on that. I don't think we can answer that. That's a true association, but it's provocative. It requires more study to see if that's true or not. I think there is some. You could think about how that would happen. Is that perhaps chronic inflammation of the kidney, chronic irritation of the kidney over many years of stones can cause some changes in the kidney, causing predisposition to cancer. Again, we don't have any strong data supporting that right now, so I think that's a tough one to answer.
The next question is from Marion Regis for Dr. Athreya. Do radiologists tend to report on the composition/consistency of tumors and changes in these, or just on the number and size?
how we report scans, just relate just to for kidney or any cancer for that matter, would be to look at the organ first. So in this case, the kidney. So we'll describe how the tumor, what size it is, and the consistency, obviously, whether it's spread locally surrounding the kidney. That's what we look at the T or the T staging for the kidney cancer. Then we look at the lymph node, which could be surrounding the kidney or within different parts of the abdomen. Once we cover that, then we look at the different organs, particularly the lung, the bones, and the liver, to make sure there is no metastatic spread. This is how we make a diagnosis and provide a provisional staging. That's for any kind of a pre-treatment treated patient. For patients who come back after surgery, we again look at the kidney area, whether it's a partial nephrectomy or a radical nephrectomy, look at the site of the tumor to identify certain abnormal tissues, if there is any, to suggest any local recurrence, and again go over the checklist to look for nodal metastasis, and again look for metastasis to the liver, lung, or kidney, and issue a final report based on what we find. So it will be looking at all these factors, whether it's patient has come for prior to treatment or a follow-up study after the treatment.
The next question is from Donna Schwan. I hope I pronounce it, is metallosis blood contamination a factor in kidney cancer?
I'm not sure. I'm not sure what, I'm not familiar with metallosis, blood contamination. Deb, do you know? Yeah.
Thanks for asking.
I'm not sure, Donna. I'll have to look it up. I'm not sure. I apologize.
And then the last one is a comment. My husband had a routine ultrasound at age 67, and the tumor was identified. No symptoms at all. So again, it goes back to what was said, that prevention and early diagnosis is very difficult without people having any symptoms at all. Are there any other questions in the audience?
I just want to make a quick comment about scans as well. So I had a patient today that had she had a possible mass in her kidney. We saw her on August the 7th, and we organized a CAT scan. It was done on August the 23rd. Her appointment was bumped until today. She came in, and as soon as I gave her the results, she started crying because she was just so upset about waiting for those results for such a long time. So the CAT scan anxiety is really a real thing. We as doctors, we do sympathize with that. I think the next step is what they're doing at Sunnybrook, which I think is a great system where they have my chart, whatever it's called, where you can log on and get your own CT results and get your own blood work. I think we're going to move to that at our cancer center as well for our patients. I know I try to enable our patients to look at their own blood work, but it's hard to enable you to look at your own CAT scans because there's no mechanism for that. Your family doctors always get a copy of your CAT scan. It's or MRI. It's by law. So your family doctors always have access to your CAT scan as well. And you can always call the doctor's office as well to get your results earlier rather than wait and be upset for such a long time. It's a real thing for sure, and we do sympathize. The other comment is CAT scan without dye. Many patients say, I'd like to get a CAT scan without dye rather than the CAT scan with dye. I would say to you that an ultrasound is better than a CAT scan without dye. A CAT scan without dye just looks at the shape of the organs. We can't see inside of it. The only way to see inside the organ and see if there's any cancer is if you get the dye. If you have a dye allergy or if your creatinine is too high, it's better off with an ultrasound or an MRI than doing a CT without dye.
If it helps, metallosis, this is from Wikipedia, is metal debris in the blood which comes from medical implants, joint replacements vibrating against one another.
So I'm not sure if everybody heard Wally. He said that metallosis is when you have metal in the blood from metal implants, prosthesis, and that sort of thing. And I would have to look up the association with kidney cancer because I'm not aware of that.
Recently, they've stopped having me drink the contrast before the CTs, and I just wanted to know.
The oral contrast.
Yeah, the oral. I still get the IV, but not the oral. I just wanted to know if that affects the clarity of the CT.
Excellent question. The oral contrast looks at your bowels, and pretty rare for kidney cancer to go to the bowel. Did you? Okay, well, you're the exception. So you got me. So for you, having the contrast would be good then. Okay, you have to check with your oncologist, but It's mainly for the bowel, so the IV is more important to see the organs. So.
Sir, did you have a question?
Yeah. Well, I was wondering if you could just, statistically, why does kidney cancer then show in the lungs next? Is it a tissue thing, size of tissue, the sensitivity of it?
It's kidney cancer spreads by the bloodstream. So the cells escape through the bloodstream to the renal vein, go into the bloodstream, and then implant in the lung. So the first place that kidney cancer spreads to is a lung, and then after that, liver, then bone. Those are the main spots. So hematogenous spread to the lung.
Is that also the same with sarcoma? I had sarcoma on the right kidney, and I had a nephrectomy.
Yeah, so sarcoma of the kidney is it's a different disease altogether, and it's more of a disease that's treated in a different way. Dr. Tozer is the expert, and he's off drinking beer right now. We'll ask him. So.
A question for Dr. Athreya. Is there a reason other than cost why a patient couldn't say, I'd prefer an MRI of the abdomen and pelvis? I understand MRI prep's not good for the chest, so just do a chest CT with non-contrast, just to get one pass on the chest. And then just as a patient choice, to say, I would prefer an MRI of the abdomen and pelvis, please. Is there a reason why we can't have that as patients?
One is again is accessibility. CT scans are easily accessible.
That's a good question. Want to repeat that? Yeah, that's a good question.
That's a good question.
Because every time I ask for an MRI, I have to basically give like a lot of part of my body parts to you guys.
One is accessible to MRI. To do an MRI of the abdomen and pelvis, it's much longer compared to how when we can perform a CT scan in few seconds. The whole abdo-pelvis is covered, whereas the MRI takes much longer. Definitely longer to include an abdomen and pelvis. You're looking at least an hour or more. And again, cost definitely is a factor. And so can we perform an MRI in patients who request? Yes, we can, but again, it depends on the standard of practice now is mainly CT. Again, how many CTs the patient has had, or are we changing the practice and moving to MRI? It's hard to say, but it's just the ease and accessibility and the quick scanning. It all takes precedence over CT than MRI.
So it's not like it's a resource issue.
Resource is definitely an issue, but again, it's what you get out of each scan. CT scan provide the same information quicker. Sometimes it's better than MR, and more chance of MRI, images getting degraded. Patients can't lie flat for 1 hour. Breath hold is not good. Then the MRI images are absolutely of substandard quality. CT scans are much faster. And the dose protocols are usually we alter the dose protocols. They're always to the minimum and to the body covered. There's no unnecessary scans or radiation or other parts being performed. So that's how it limits the dose of following a CT.
So I had a question about PET scans with kidney cancer. If you can maybe talk about that and why it's not really, we've never even touched on it today.
It's I don't do PET CTs. It's really difficult for me to comment on that actually.
If I can comment a little bit, I think the literature on PET CT scans for kidney cancer is lacking. So PET scans are used mainly for lung cancer and other cancer types, but for kidney cancer, there's no strong data to support that it's better than other imaging modalities. So in fact, we have had a few patients ask for a PET, and when we've sent them off for PET CT, we actually can get that. It doesn't add a lot of extra information for us in terms of helping. If we're worried about finding an area of cancer that's not there, there may be some utility, but we need to do more study in that area.
I just want to ask a question. In terms of like when you're doing a partial or a radical nephrectomy, when you take the nodes, do you take them regardless of whether they look okay? If you take some of the biopsy,
But you take the original with them?
That's a great question, yeah. Yeah, so the question is whether, when you do a nephrectomy, if there's nodes that are there, we take them. What if there's no nodes that are visible, do we take them? And the answer is no, because there's often just no tissue there. It could be just like a string of tissue. And so it's a little bit, it's actually more difficult than actually doing the nephrectomy to take the nodes out, because the nodes are in the crevice between the aorta, or the big blood vessel, and your spine. So if you get a blood vessel and a bleeder in there, it can be pretty significant. So that's where experience comes in, because if you have bulky nodes, taking that risk is worth it because you could potentially go for a cure. Whereas if there's no nodes there, taking out that strand of tissue, which is most likely benign, is too risky. Yeah, good question.
Okay, final question?
Well, this is more of a comment. I just wanted to say that we've been very fortunate because my husband has cancer, and when he's had his scans, obviously it takes like a week or two before it gets to the urologist, the actual scan, and he has to look at it and do everything. But we've been very fortunate that they send like a written report of any changes directly to his family doctor, and we go the next day to find out what kind of results to his family doctor.
I think that's a great idea.
And I'm sorry. I'm sorry, but that's what we've done, and it kind of eases. I mean, you still have that worry and concern because you don't know 100% of everything, and sometimes the written doesn't give you everything, right? But it did ease a lot of that anxiety that you're talking about. Just hearing that, okay, no, there hasn't been growth on this or that, you know, like there might be some change on this, but not on that. And it kind of eases a little bit than waiting that 2+ weeks to just get in to find out anything.
I think there's that point is valid. I think it's the radiologists in their defense they're pretty swamped. They're working pretty hard, and it's tough to always practically do that. But I think access to your own record is really the future, where we enable patients to access your own records, your CAT scans, your blood work, and the notes that we dictate. By law, we have to dictate a note to your family doctor. I think you should have access to your own notes so you know we're all on the same page. And that's just the future. It's going to happen very, very shortly.
I wanted to thank both of you for sharing your expertise in such a wonderful manner that all of us can understand. I also would like to say, please fill out your evaluations that you have so that we can learn how to better the talks that Kidney Cancer Canada is arranging. And thank you for coming out. I think the evidence that has come out of this meeting tonight shows, again, every patient is an individual. The amount of information that you can gain, if you're not the type of individual to want the information, make sure somebody is so that you can partner in your health care and be a partner in the entire treatment of your kidney cancer. So thank you, and good night.